Good afternoon, good morning, good evening to some of you maybe who are joining from different time zones. Welcome to this first webinar on patient advocacy on AMR in the EU. Where do we begin? We aim to bring together today the patient community to discuss how to raise awareness of antimicrobial resistance and how to amplify patient advocacy on this important topic. This webinar is the first of a series of 3 webinars that we are jointly organizing, the European Patients Forum, as well as the AMR narrative, and we'll give a little bit of information about our organizations a little bit later. So I'm Claudia Luati, I'm the head of policy at the European Patients Forum, and I'm here today with my colleague Francesca Chiara from the AMR narrative. Francesca?
Thank you, Claudia, for the kind introduction. We have designed this joint webinar series to highlight the impacts of AMR on patients and emphasize the importance of patients and community participation in global AMR advocacy efforts. Patients are at the front line as they utilize healthcare facilities, are required to take antibiotics for many routine procedures. They are more susceptible to infections due to their weakened immune system and invasive procedures. In view of the rise and spread of resistant infections and pathogens and hard-to-treat infections, patients face the challenge of having access to effective treatments. This, of course, can result in worse outcomes, longer hospital stays, as well as increased mortality. These impacts on patients and their carers as well. As we will hear from patient stories and our panelists today, resistant infections threatens patients' access to care, not in a distant future, but now. So what do we need? We need better awareness in the EU, but also globally. This issue is well understood technically, but we need better participation from our decision makers. The objective of this 3-part webinar series is to provide a platform for dialogue for patients to foster advocacy efforts. We aim for a diverse group of patients to come together, to share their stories and connect with each other. So we have a very packed schedule today. We are going to start with Dominique Monnet from the ECDC, which talk about AMR in the European Union and the situation there. We will also hear a patient survival story from Ella Balasa, and we will then conclude with a panel discussion. We have 4 patients today joining us, which will discuss about reaching out to a diverse patient population and how to do that. Thank you.
So just a few housekeeping rules. We're all used to online meetings by now, I believe. Please use headsets to mute yourself if you're not speaking. And if you have any technical issues, you can use the chat box. We will not be able to give the floor to participants today, unfortunately, due to a lack of time, but we'd like to have your questions, comments. So do use the Q&A chat at any moment if you'd like to ask a question or if you have a remark. Also, just to note that this webinar is being recorded so that it can be then posted afterwards on our YouTube channel. So just a few words about the European Patients Forum. We are an independent, non-governmental umbrella organization of patient organizations across Europe. We were founded in 2003 and we're based in Brussels. We have about 79 member organizations at the moment that are national coalitions or that are umbrella organizations of disease-specific organizations at EU level. So really our vision is a Europe where patient organizations are valued partners in creating equitable, person-centered healthcare systems, and we advocate and we help our members advocate for policies that advance the interests of patients and patient communities. I think, Francesca, if you can go to the next slide.
Yeah, so just a few words about the AMR narrative, which is the other organizing partner in this webinar series. So the AMR narrative is a UK-based charity, which was founded in 2022 by Vanessa Carter, who is the AMR patient survivor, as well as AMR advocate. I'm currently serving as the chair of the board of trustees of the AMR narrative. We have also other 7 trustees and 10 independent voluntary advisors. So how the AMR narrative works. So the AMR narrative was established because of the needs and in the recognition of the fact that we need patients and the public center activities around AMR in a continuous way. So we need continuously to have patient participation in the AMR sector. We are working on 3 different pillars, which are focused on developing patients and public advocacy, as well as promoting understanding of AMR and fostering a global community. Of course, we advocate for a One Health perspective, so we're not solely focused on human health, but also we look into human, animal, and food and agriculture and the environmental sector. So AMR is, of course, very complex issues that require the involvement from different stakeholders. And part of our vision is not only to provide stories from patients, but also to foster meaningful participation of patients in the AMR field.
So without further ado, I think we'll move to our first speaker today. So Dominique Monnet, who will give us an overview of AMR, what it is, where we stand in the EU on AMR, what is the current situation. We thought it would be very helpful to have a definition, obviously, and to make sure that we all have the basic understanding of the situation. So Dominique, I'll turn to you. We've given you the impossible task of giving us this presentation in 10 to 12 minutes. So please, the floor is yours.
Yeah, thank you very much for the invitation to ECDC. So let's move immediately to what concerns us. I don't like the acronym. I personally don't like the acronym. If you ask people down the street, they would not know about the acronym. They would actually have difficulties with antimicrobial resistance, whether to say it and certainly to understand it. So what are we talking about? We're talking about the ability of microorganisms, often bacteria, but there could also be fungal pathogens, to withstand the treatment that has been designed to treat the infection. These are bacteria and other microorganisms, and they develop resistance to antimicrobial. It's not the patients, it's not the people that develop resistance, and that's another common misunderstanding, and we need to work further on this. How do the microorganisms develop antimicrobial resistance? Either chromosomal mutation or the transfer of genes that confer the resistance through plasmid and transposons between the microorganisms, and then often there is resistance to multiple antimicrobial agents. So we're talking about drug resistant, extensive drug resistant, and sometimes even totally drug resistance, or what you call pan-drug resistance. How can this happen? Either selection of a resistant microorganism when the antimicrobial agents are present in an environment, a setting, humans being treated, animals being treated, or effluents in the environment. And the other mechanism is the spread of the microorganisms that have resistance between humans, between animals, between animals and humans in both directions, and between animals and humans and their environment. At ECDC, we actually see it as a continuum. That is, we raise animals. Some of the animals are slaughtered to become food. The manure can be used to fertilize vegetables, and then we can acquire resistant bacteria from the food that we eat. In the community, some of us will have infections and we need to be treated with antibiotics, and that will lead to resistant bacteria. Some of us will be unlucky and have to be hospitalized, and there the need for effective antibiotics is essential, starting from for prophylaxis, for surgery, and also for treating infection, in particular in the most specialized part of the hospital. I'm thinking about intensive care units, bone marrow transplant units, or patients with special conditions that rely on antibiotics. And then we have resistance being transferred, brought to the EU, and I'm talking on an European Union standpoint, either when patients that have been hospitalized abroad need to be repatriated and hospitalized in a hospital in Europe, or even when we travel without contact with healthcare, and I will come back with an example with this. So we have a video at ECDC, and I will not show the video today, but I invite you. I think it's a good explanation on how we see this issue that, of course, is one health issue, but the compartment do not play the same role. Trying to move to the next slide. Yes. Yes. But still, it sounds complicated, right? I'm talking about several compartments of healthcare, but also the food animals, the food, the environment. When we deal with humans, it's not one type of infections like Mycobacterium tuberculosis that would give TB, but many types of infections. We need to differentiate between healthcare-associated or hospital-acquired infections and the community-acquired infection. We need to differentiate between the patients that are only carrying the bacteria without being infected and the one that really suffer an infection that will require treatment. And then you hear about strange Latin names of microorganisms, many names of antimicrobials. The microbiologists kick in and they're talking about genes, about mechanism of resistance, about the spread of clones and of resistances between bacteria. But quite frankly, it's very simple. We're talking about patients that have infections that are due to microorganisms that are resistant to multiple antibiotics. Therefore, the infections are difficult to treat, and sometimes the outcome are not what they should be. Let's take the example of Eric as a patient who, as a teenager, suffered leukemia. And during her cancer treatment, she developed an infection with the Klebsiella that was resistant to even the last line drugs, the carbapenems. So she needed to be treated by even more last line antibiotics, and I think she was treated with colistin, and colistin has toxicity. The doctors had to stop her cancer chemotherapy, treat the infection, but hopefully the infection was treated. The cancer chemotherapy was resumed, and 12 years later, she's alive and healthy. And thanks to her, she was able to tell us about her story. We have several other stories, and we'll hear one story today. But I think this is what speaks. If we want to raise awareness, we need to put patient forward, and you, of course, support this approach. This is how it looks when you receive a result. And this could have been Areti's result. So nothing works, except in this case, 2 old antibiotics, the newer antibiotics at the time. So why do we talk? If we don't say AMR, if we don't say antimicrobial resistance, should we say antimicrobial resistant infections? Still difficult to say. In the US, more and more people are using drug-resistant infections. That may work. I'm not sure that works in Europe, where the word drug has another meaning, but we definitely need to find a new name. So where are we in Europe with those infections? We did an estimate, the second estimate, and we published at the end of 2022. We estimated that in Europe, there are more than 800,000 infections with antibiotic-resistant bacteria that result in more than 35,000 deaths directly attributable to these infections. It seems a small number, but it's about 100 every day, and then 100 again the next day, and then 100 again the day after. We just don't hear about them. They're scattered all over the hospitals in the EU. These infections result in more than 1 years of life that are lost because of premature death or disability, and more than 70% of this burden is linked to healthcare-associated infections. It's not small. It's comparable in the EU to the burden of influenza, tuberculosis, and HIV/AIDS combined on a year without COVID. And it increased since 2016, but decreased during the COVID pandemic. It varies a lot, even when we control for the size of the population between the countries that we're working with, in disability-adjusted life years per population on the left and attributable death per population on the right. Some countries, obviously, when controlled for the population of the country, carry a heavier burden than others. We now have indicators and targets that need to be achieved by the EU and by the member states for MRSA on the left, and it seems that we slowly going to the 2030 target with a starting point of 2019. For third generation cephalosporin resistant E. coli, the target is always reached. There have been a major decrease during the COVID-19 pandemic, but also decreases in antibiotic use in animals. So it's probably a sum of the two. But what we're really concerned about is Klebsiella pneumoniae bloodstream infections that are resistant to even the carbapenems, multi-drug resistant and also resistant to carbapenems. And here the EU and many member states are going against the fixed target, which was very reasonable of -5%. The reason why we're not seeing it, and you see the colors slowly changing here, is that the variation is little and little, and what we're dealing with is not a big wave, it's not a tsunami. It's more like slowly rising sea levels from one year to the next that suddenly impair our ability to treat infections. So it's another reason why it's difficult to communicate. It's not like a COVID-19 pandemic where the situation in Europe changes within 2 months. From we hear about the first cases to the hospitals in northern Italy start having major difficulty coping with the influx of patients. A last point about resistance that worries us, start worrying us, is when we travel without contact with healthcare. And this is a study that was done in returning travelers that were negative upon departure. And you see that 72% of those that returned from Asia had multi-drug resistant Enterobacterialis in their feces. 3 of them actually had carbapenem resistant bacteria, and a bit less in the other continent. That was in 2013. What is the situation now? Unfortunately, we don't know, but I suspect that it's even worse. What do we do? Well, new antimicrobial agents, of course, but if the new and there are new antimicrobial agents being available for treating patients in Europe, but if we use the new antimicrobial agents the same way we used antimicrobials in the past, we'll end up with the same situation. So we need to be better at, or more prudent at using antimicrobial agents only when they're needed, and if they're needed with a correct dose intervals, correct duration, and then being better at hygiene, being better at infection prevention control, starting with hand hygiene and then screening patients for carriage of a multi-drug resistant bacteria and isolating those patients. What do antibiotics do to us? This is a study that was done in volunteers in Antwerp, Belgium. And you see, and the patients were given either a placebo or a type of antibody called macrolide. And what the researchers measured is the percentage of the volunteers that would have macrolide-resistant bacteria in their throat. And that's what you see on the y-axis. And you see that the one that received a placebo, I mean, there's a small proportion of them that always had, before the study or after the study, macrolide-resistant bacteria. But look how it quickly goes up. This percentage quickly goes up in the one that are exposed to macrolide. And even after 6 months, there's still double the percentage of carriers of resistant bacteria than the one that received the placebo. So how long does it take to come back to the baseline of 20%? 9 months, a year, and then winter comes again, and then we take antibiotics again, and then we're back up to 80%. So this is a reason why it doesn't make sense to take antibiotics when they're not necessary. Not surprisingly, more a country uses antibiotics, and here I put the macrolides on the left on the x-axis, the higher the percentage of infection that will be resistant to this antibiotic. And on the right, you have the example of E. coli for another type of antibiotics. I could have produced a slide with many of those scatter plots. The more a country uses antibiotics, the higher the percentage of the population that uses antibiotics, the higher the resistance. And in the EU, antibiotic consumption is slowly decreased during the years of the COVID pandemic, because, I mean, there were lockdowns, schools were closed, people were at home, there were less exchange of bacteria and less infections and less need for antibiotics. But see, in 2022, we were back to this line with a decrease that hopefully will continue. Not countries have the same issues. So we have at ECDC since 2008 conducted or coordinated a European Antibiotic Awareness Day. This gave the encouragements for WHO to develop a World AMR Awareness Week, and this is continuing in the EU. We've developed a lot of materials, including key messages for the general public that warn about the risk of self-medication, plenty of messages for healthcare workers. If you're looking for narratives, if you're looking about ways to explain, if you're looking for the evidence behind the key message of a statement, I invite you to look at those, because a lot of the work has been done and the reason for the various actions that are recommended have not changed. We also produce videos that can be used that are already translated with subtitles in the EU, official languages, and I invite you to go there. And we also have videos about hand hygiene that are self-explanatory that you can also use. So I will leave you on this. We'll have, of course, another European Antibiotic Awareness Day on 18th of November, the first day of the World AMR Antimicrobial AMR Awareness Week, and I hope we will be able to work together. Thank you very much.
Thank you very much, Dominique. Perhaps just one question for you. As patient advocates, what would you recommend? How to raise increased awareness? It seems that there are some trends that show decrease in antimicrobial consumption, but since you joined the CDC in 2007, do you see increased awareness, and how, as patient advocates, can we raise awareness? What should we ask for?
We decided from the beginning that if we raised awareness about antimicrobial resistance, that would be difficult to explain. And then we knew that in one country, this had been used to promote the sales of a new antibiotic. but been used by a pharmaceutical company for this. So we decided to go for prudent use of antibiotics. Colds, flu, take care, not antibiotics. And the message, if you look at the various Eurobarometers that are conducted by the European Commission, the awareness is increasing, and the percentage of respondents that said that they took antibiotics during the past year is decreasing. So if targeting the general public, I think I would do this. And I would also remind people to wash their hands, and if there's no sink and water available immediately, then disinfect their hands with alcohol-based hand rub. Thank you.
Thank you.
Our next speaker is Ella Balasa. Ella is a patient advocate living with cystic fibrosis, and due to her struggle with the condition, she has faced several resistant infections, and also she has undergone experimental treatments. She has committed to advocate and empower other patients, as well as advancing research strategies through her connections with researchers, pharmaceutical companies, and patients' organizations. We are gonna listen a video from Ella.
My name is Ella Balasa, and I was born with cystic fibrosis, a disease that causes a battle to rage inside my lungs between antibiotic-resistant bacteria and my body's immune system. It makes me susceptible to chronic infections, and I'm running out of effective antibiotics to treat them. CF affects many organs, including the digestive tract and sinuses, but in the lungs, it is especially dangerous, where naturally occurring mucus in the lungs becomes thick and sticky without hydration, trapping particles and bacteria with each breath that I take. And because my body can't clear out this mucus, the trapped bacteria then starts the cycle of infections for people with CF. And these repeated infections also cause permanent lung damage and ultimately lead to a shortened life expectancy. And to suppress this bacterial growth, I've had to use countless courses of antibiotics, both intravenously, orally, and inhaled, for many weeks in the hospital throughout my life. And these antibiotics have been cycled every few months to suppress the infections, but rarely can CF infections be completely eradicated. And with each antibiotic cycle, the bacteria that remain get stronger, gain more resistance, and over time, the antibiotics have just become less effective and the infection's more difficult to treat. In 2019, I faced the most severe drug-resistant infection that I've had. My doctors used the strongest antibiotics that we have available to us today to control the bacteria in my lungs. I had antibiotics pumped through my veins 24/7 for weeks, but I wasn't getting any better. I was coughing endlessly, unable to breathe without supplemental oxygen therapy flowing through my nose, and I realize now how sick I was. I was barely able to walk a few feet, and my lung function had dropped 18%. I was a shell of an existence. The bacteria in my lungs were stronger than the strongest antibiotics that we have. And this is when I heard about an experimental treatment called phage therapy. And I have a biology background and worked in a research lab and was always interested and involved in understanding new research in CF, new treatment availability, and I decided to try this experimental treatment and was willing to take the risk because I really had no other options available to me. And luckily, it did subdue that infection. I traveled to a research center to receive phage therapy, and this treatment is the use of a virus, a very specific virus, to attack a bacterial host. And so knowing the state of the infection that I had and the low lung function that I suffer from, I do consider this treatment to have been a success in clearing my infection. And I wanted to share about this experience and not only show the power of self-advocacy, but also raise awareness of phage as a potential viable treatment against bacteria, though much research is still needed. And that experience, as I said, made me want to share my story, because my story of AMR is just one of many. And the more that I've learned about antimicrobial resistance and interacted with other patient advocates, with the research community, in the legislative arena and policymaking, the more I've realized the scale of this issue. And so this was the beginning of me sharing my experiences on the public stage, at conferences and meetings, giving presentations, speaking on panels to pharma companies, researchers, investors, policymakers, congressional staff in the US, and also being a part of numerous documentaries sharing my story. And I've now been invited to share at the Milken Institute, the Infectious Disease Society of America, the FDA, the Presidential Advisory Council on Combating AMR Bacteria, the Sepsis Alliance, and last year was selected as part of the World Health Organization Antimicrobial Resistance Survivors Task Force. And this is a committee that's comprised of patients and caregiver advocates all over the world who advocate in their respective regions to help humanize the experience of people who have dealt with AMR. So I aim to bring awareness to this growing problem, to encourage and inspire the research community to pursue new viable alternatives, and encourage collaboration for new innovation, funding, and better health for people. I've lived my whole life in fear of new infections, and until my battle is over, I really call for every person who's dealt with AMR, or knows someone who has, or has just been compelled by hearing my story or someone else's, to support this global crisis. Because we need to share our stories, we need to humanize this problem so that AMR isn't going to be the greatest threat to many people's lives, including mine. So thank you.
That was a very important story, and as Ella says, it's important to humanize this issue and to put faces on the issue, to really understand what it means, what AMR means for patients, and what we need to do about it. So I think we'll move now to our panel discussion. We have 4 patients with us today who will also be there to tell their story and to humanize the issue. If you can go to the next slide, Laura. Oh, we're missing the slide about the panel. Oh, here it is. Perfect. So as I was saying, we have 4 patients with us today, and I'll invite them to join me here. So we have Vanessa from the AMR Narrative. We have Lynne Van Poelgeest from the World Federation of Incontinence and Pelvic Problems. We have Gavin Schranz, who is a renal patient and member of the WHO Youth for Health network. And we have Krista Bracke, who worked as a journalist and is now a patient advocate for the European Sepsis Alliance, which is part of the Global Sepsis Alliance. So really 4 different perspectives coming from different disease areas and have different experiences of AMR. And that will lead me to my first question to them, which will also allow them to introduce themselves, which is, please tell us in a few words about your organization, your disease area, your personal experience, how AMR affects your community, how it affects you as a patient, and why and how you've engaged in the topic so far. I'll start maybe with Vanessa. I'll give you the floor. Thank you.
Yeah, thank you so much, Claudia. And I think that, you know what, so far, especially from Dominique, I gathered so much information. Yeah, so as you can hear from my accent, I'm originally from South Africa. I'm now living in the UK for the last 3.5 years. So from my perspective, I had a hospital-associated infection. I had a 10-year facial reconstruction. And, you know, in my 6th year, I had an infected facial prosthetic that ended up in a very highly resistant MRSA. So that's the acronym, methicillin-resistant Staphylococcus aureus. It took me a long time to get that pronunciation right. Infection that nearly, you know, cost me my face. Yeah, I think one of the biggest issues that I had when I started my advocacy was the lack of understanding of AMR. You know, I worked in marketing at the time, and I sort of said to myself, why are people not talking, you know, doctors not talking to us about this? Why is it not common knowledge? You know, why isn't it something that you know, that I couldn't have known better? Because, for example, you know, I would take my antibiotics, sort of stop them halfway because, you know, and then go see the next doctor. So I think my advocacy was really driven around that. You know, we need to create more general awareness, you know, general knowledge. You know, if you go out into the sun and you don't apply sunscreen, you know, that's kind of like a general knowledge question. You know, you could get cancer from doing that. Well, you know, if we stop antibiotics halfway, or if we overuse them, this could result in antibiotic resistance. So that's kind of the place that we need to get to. And to kind of answer your question also about what I do right now, I started in a hospital bed. I have no scientific background. As I said, I have a marketing background. And I started very small. You know, I started with a blog, and I built that up over the years. I started networking. Yeah, and eventually now, yes, I've become the chair of the WHO Task Force of AMR Survivors. I've also been the first patient member of the Strategic Technical Advisory Group with the WHO. And in the last month or two, I've also opened up the United Nations multi-stakeholder meeting and spoken at World Health Assembly Roundtable. But yeah, but I started small, and I think that's important to kind of bring that across. You know, you start small. And I'll speak a little bit about that more later on. But, you know, we have to start somewhere as patient advocates and whatever we're comfortable with. So, yeah, thank you.
Thank you. Marilyn?
Yes, hello, and thank you for the invitation. It's a huge, huge topic, so it's very difficult to say in a few words. But I've got two hats here. I've got a hat as a patient advocate and the spouse of my husband, who ended up with antimicrobial resistance and some of the effects of mistreatment, which I'll speak about in a moment, and also as a global organization dealing with incontinence issues, so therefore UTIs and the damaging effects, if you like, of overuse of antibiotics when it comes to treating urinary tract infections. So, and awareness, as you're saying, this is key. We've got World Continence Week this week, and it just shows that raising awareness in a proper real world data with the correct data is key. And I think that whenever we're talking about this famous AMR, which I hate the term as well, I think it's ridiculous because most people don't know what AMR is. And I think that we really need to, thank you very much for mentioning that. I think we need to take a good look at how we're going to refer to this kind of resistance. So that's something we could maybe do a competition about it and see what's most effective. But if I look at, I'll just take what happened to my husband in just a couple of words, because it would take far too long. He ended up with a diagnosis of 2 bacterial infections, and was treated with a PICC line. We had to come home with a PICC line and Lord knows what he had. I had to deal with it solo. I'm not a medic, but it was very difficult to, in a home environment, to deal with those issues. But the one major, how should I say, error was that the pharmacist at the hospital and the local pharmacist who misinterpreted the dosage and actually put in the cassette to administer 10 times the dosage. And it was only a very alert health visitor who came, who actually saw this, because otherwise you can imagine it would have been curtains in no uncertain terms. So I think communication amongst all the various people who are involved at whatever level is key. The correct diagnosis, the correct communication, and so that was one thing from, as I say, from a personal point of view, that was pretty scary what happened there. And then the second thing I think is this notion of there are so many, I've said it before now many times, there are so many different groups out there all doing their own thing about AMR. I mean, you just look at what you get in LinkedIn or whatever every day, and everyone seems to be going off at a tangent. Wouldn't it be great if we pool our resources and come together and unite in a common effort to combat these very prevalent issues, which are only going to get worse, as we know what the figures are. So I would make a plea to actually see how we can actually sit round a table and do that. I think that is extremely important, so as we don't get all sorts of disparate bits going on here, there and everywhere, which, if you like, dilute the effect. I'm trying to use the right words, but I think this is the way forward, that we actually come together, all the stakeholders, everybody involved, and see how we can influence the policymakers, especially if I look in Europe with the new parliament, the policymakers. This is the beginning, this is where we start, and we have to lobby and really go the whole hog to make sure that we get this on the roadmap. I'll leave it at that for now.
Thank you very much, Marilyn. Thank you for this call to action and already thinking about the solutions. I'll turn to Gavin, if you want to give us your experience.
Thank you, Claudia, and thank you for the invite. Hello, everyone. My name is Gavin. I'm a renal patient from birth, basically. Over the years, I've had multiple major surgeries since childhood, so nephrectomies, cystoplasty, stoma, nephrostomies, lots of different procedures. And naturally, due to these, I've managed to overcome many different infections due to the open wounds and different access, and also the fact that my bladder is made up partly by the large intestine, which continues to produce mucus and cause sort of infections in the bladder. I'm currently on dialysis. I just recovered actually from MRSA in my fistula wound. So that's another example of narrow spectrum antibiotics that were used to overcome this. And I'm preparing for bilateral nephrectomies, both removal of both kidneys and an eventual transplant in the coming months. So I've been warned about the risks, the high risks of sepsis, and I'm trying to do what I can to prepare myself for the coming months. That's one hat as a patient. The other hat, I'm currently finalizing my master's in digital health at the University of Malta. And my thesis is actually the development of an e-learning tool for the Maltese public, to educate the Maltese public about the prudent use of antibiotics to reduce the self-medication of the Maltese public, given that latest Eurobarometer surveys show that Malta self-prescribes the most in the EU. So that's my current focus.
Thank you, Gavin. Thank you for sharing your story. Krista?
Yes, thank you for inviting me. I'm Krista Bracke. I'm from Belgium. I used to work as a journalist for the Belgian National Radio until 2009, when I was infected by the Streptococcus pyogenes bacteria. I had multiple organ failure, developed a sepsis, went into a septic shock. I was in a coma for about a month and a half, had to be ventilated, had to be reanimated for several times. But I survived, luckily, not without consequences. I had a double below knee amputation, so I now have prosthetic legs. And I tumbled from one pneumonia into another as well during that horrible year, 2009. And in the end, I got the diagnosis of primary immune disorder, which apparently did not cause the infection, but it made it more aggressive, more severe. Now, over the past 15 years, I have been coming more to participate in health and how we receive health and how we can work together with health professionals. And I started doing patient advocacy also for the European Sepsis Alliance, which is a part of the Global Sepsis Alliance. And it became clear that actually in 2009, I was saved because of the fact that there was a cardiologist, without having the scientific proof of what really happened to my body, that I had developed a sepsis. Without having that proof, he said, well, my intuition says that something isn't right. I have to act and I have to give a broad spectrum antibiotics. So in a very early stage. And that has been life-saving. My intensivist later on said, if my colleague hadn't given you that antibiotics, I couldn't have helped you anymore. I couldn't have resuscitated you anymore. So antibiotics are really crucial in the treatment of sepsis patients. And that's why AMR is like a sort of sword of Damocles to us. Let me maybe illustrate this by means of a slide. I think, Claudia, it's possible to find that slide maybe. Yes, a slide which illustrates the sepsis and the AMR burden. You can see that yearly there are about 5 million AMR-associated deaths. And these 5 million AMR-associated deaths are actually part of the over 30 million sepsis deaths yearly worldwide. So actually the AMR burden is part of the sepsis burden. This data we get from the Institute of Health Metrics and Evaluation. And so that's why I'm really very happy that we were, as a Global Sepsis Alliance, invited to join this debate because we have the same enemy, we have a common enemy. Yeah.
Thank you very much, Krista, and thank you to all of you for sharing your stories. You've alluded to some of the challenges already, which are indeed lack of understanding, lack of awareness. What do you think are the challenges in mobilizing patients and patient groups to advocate on AMR, and how can we overcome those challenges? Marilyn, you've already mentioned the possibility to bring people together and to try to advocate together, but what is holding us back at the moment? I don't know if,
yeah. Okay, I'll start. Then I think what's holding us back, a couple of things. First of all, is the sort of common general knowledge, lack of knowledge. The general public just do not recognize this as a problem or an issue. They don't really know about it. As you said, with COVID and one thing or another, people got sort of COVID savvy because there was so much out there. But to get proper, trustworthy information, general public, in a language that's not pedantic but understandable and not too lengthy, not too wordy, I think that's quite a challenge. That's number one. And if you're a journalist, you know exactly what I'm saying there. And I think we need to unite and get that message across. And I think the other message is to bring the various parties together. Now, how we do that? Well, we start with this webinar today, and I think there's a huge role for everybody here today, and certainly for the EPF with the 79 members. We're members of the EPF as well. I think this is something that we can actually disseminate amongst the many patient organizations and the scientific societies. Please let's not forget that a lot of information circulates via the various scientific societies, and it's not one particular pathology. I think it's across the whole spectrum. So that would be my prime goal, if you like, and I think we're all passionate about what we're saying, so I'd like to see what the others have to say.
Well, I think that there are really a lot of similarities between the AMR situation and also the situation of sepsis, because sepsis, well, it's something strange, something unknown to a lot of people as well. In some countries have created a lot of awareness already, but a lot of them have not yet. So that's a problem we share, and we should try and create more awareness. And I think in the case of AMR, it's very difficult, it's very abstract for people. So maybe it could be better to focus on the consequences of AMR for different people in different situations with different diagnoses. It may sound a bit provocative to say, but I think we should regard it as an invitation. It's not AMR which kills people, it's actually the infection which does. So indeed, like you just said, Marilyn, we should join forces. Let's move forward together in the prevention of these infections in general, and also in raising awareness of AMR, raising awareness of sepsis, and also improving in early recognition of symptoms, of sepsis symptoms.
Gavin, Vanessa, do you want to come in?
Sure. So piggybacking on what the others said, what I found from my study is actually quite interesting in that the Maltese public, for example, have quite a high knowledge of the implications of AMR, the causes of AMR. However, it doesn't match with the behavior. So what my 2 cents is, how are we going to translate the results of these campaigns and these education initiatives into real behavior? And that's what I was trying to tackle through my thesis. What I can say from a patient perspective in improving advocacy, something that I've overcome in the past year, I would say, are 2 things. One is the stigma of admitting that you're a patient and that you have a challenge and that you're having difficulty. And this is the first step, I would say, towards improving and educating others. The second step is I found a sense of helplessness, I'd say, in the past 6 months, where I didn't see the results of my actions. I thought they were ineffective at the time. Now that's changed. I know that just sharing a survey with my friends as part of my thesis enabled my friends to be more educated. They asked me questions and so on. So now I sort of realize that these little actions do have an effect. So I think that every patient, in order to become a patient advocate, has to overcome this stigma and the sense of helplessness to achieve that.
Yeah, Claudia, sorry, you asked me to say something. Yeah, I think one of the biggest things for me is I think that, you know, when we start talking about advocacy from a ground level, me personally, when I started, you know, I came from a hospital bed, and I think many of us did. You know, I had a non-scientific background, and I started from very small. And I think that's really important to, you know, when we start talking about, like, how do we build a community of, you know, patient advocates. Does that mean speaking on stage? Does that mean, speaking with the media? Does that mean simply, self-advocacy, talking to our doctors? And so, I'll give you a bit of a background, when I first started, I just said, well, what do? I started blogging. It was a blog that I put together, and I said, this is what happened to me. And I was really scared to do that, I'll be honest with you, because I thought somebody's going to lock me down. Somebody's going to shut me down, because I shouldn't be talking about this, should I? I'm not a healthcare professional. But that kind of got me to the next step. And the next step 11 years ago when I first started was, creating a LinkedIn profile and then starting to network with the other people. And then, looking at like opportunities to get involved in conversations like this right now, as you said, Mary Lynne, conversations like this right now to learn from others and to grow myself. Because I think we all know advocacy it's not an easy job. It's a very toiling job, especially when you have health conditions that kind of hold you back as well. But I think we can all do something, and I think that, that very high level is then working within, for example, how do we get to that point where we work in the national action plans? Where is the patient voice in that sense? And how do we actually do that? So, like I said, I've worked in different realms. Medical education. I've gone to universities and I've asked them if they have stewardship programs. And I've said to them, like, are you involving patient stories in that stewardship program? Because, the nurses, and I've actually taught that, the nurses and the young doctors and the interns and so on have learned so much to say, wow, now we actually know why we're doing this. Research and development. Again, I don't have a medical background, so when I got asked to co-author publications, I was like, wow, how do I do this? So I think also mentorship programs are really important, and that's what we're trying to do also as a charity. To say, well, it's important that we work together. And as you said, again, both Gavin and Mary Lynne, we work together because if we're going to build a community of patient advocates and not just delivering the message at a political level, but delivering that message at every other level, medical education and community raising awareness and so on. How do we do that? So yeah, I think I'll leave it at that. But as I say, for me, I never thought being in a hospital bed, this is where I would be speaking at the UN and so on. But I think partnership is so key, as you said, and I think working together we can potentially achieve that. So yeah, thank you.
Thank you very much, Vanessa. And I see the time, we're almost at time, but I'll just ask one last question to our panelists before I turn back to Francesca to close. And what would be one piece of advice you would give to patient advocates or to patient groups that want to become more involved in the AMR debate and in AMR advocacy? I'll start maybe with Krista.
I think indeed we should create a multi-stakeholder dialogue with patients, clinicians, politicians, industrials, journalists also. They can actually play a huge role. They did in Belgium, for example, in creating awareness for sepsis. There was a sepsis survivor who had written a book, and it was published at the same time that a documentary on sepsis was made on television. Actually, the survivor, she managed to convince the television makers to make that documentary, and this had such an enormous impact that the Minister of Health really felt obliged to start taking action, to start moving into organizing everything so that a national sepsis plan for a national action plan for sepsis could be started. So that was really very powerful. And I think as patients, we can empower each other. We can learn from each other's actions, from how creating awareness, for example, by using a podcast, for example. There's a very good way it has been in Sweden to create more awareness about sepsis, because podcasts apparently are very popular in northern countries. So sharing these stories, looking for a way in which you can reach the general public is really very important, and come together and empower each other, like we will be doing in September the 9th in Paris. There will be a huge sepsis event, especially for patients, created by patients. We're all patients trying to organize this, and we invite patients from all over Europe and elsewhere. It's also an online event. So also AMR patients are really welcome. And we would like to share our experiences and empower each other in order to become more visible and create a huger impact.
Yeah, just a couple of things. Yes, I think multi-stakeholder alliance, that's number one. And what we've found, certainly when we're talking about continence issues, and it's working, it's taken 20 years, but it's working, is engage media at all levels, engage and collaborate with the scientific societies so that you have a foothold and that you have a say. I think this is key to moving forward. Yeah. Gavin?
I would say storytelling. I think especially in the past 10 years, we're overloaded with information, resources, reports. Everybody's got a smartphone in their pocket. So as such, I would say that storytelling is the way to go. You have to add a personal touch to the learning outcome, so to speak. And this is already being done by ourselves as patients and by Vanessa, for example. So I think this is the way to go. It gives a way to relate to the person, because everybody knew someone who has that condition, for example, and that could spark something in the public.
And one other thing, don't take no for an answer. Keep going.
And be patient, because it's always a long way.
Yeah. Should I end with that? I think all of you have said like amazing things, and I think that number one is be patient. There's a little bit of a, like a playoff on that word, be patient, but it's absolutely true. It takes a long time. And I think my closing remarks would be, start small. Don't expect to change the world in a day. But believe that you can. Believe that you can, because your voice matters. And it's one story that can change the world. It's many stories that can change the world even more. So yes, I think that's my closing remark. Thank you.
Thank you very much for your great insights. Francesca, back to you.
Yeah, so I would like to terminate this webinar, first of all, by thanking our speakers and patients for joining us today and for telling us about their stories. We heard 5 very different stories in different disease areas, and also their journeys about approaching AMR advocacy and their efforts to really improve communication in AMR. We also heard from Dominique Monnet, who has shared numbers about the situation, AMR situation in the European Union, and the work, the incredible work the ECDC is doing to raise awareness and also raise patient and the general public participation in the EU. And also we heard some practical recommendations on how we could drive things forward. For instance, we of course need to simplify the AMR messaging to make AMR more understandable to the general public. We need to focus on education, and also we need to join our efforts to build a community with represented by different stakeholders in AMR. And also drive behavior change. So this is the first webinar of a 3-webinar series. We have 2 more webinars scheduled. The second one will be on the 29th of August, and the third one and final one will be on the 12th of September. We will be sharing soon the agenda and topics of discussions with the 2 webinars via social media. So please help us share the webinars and join us as well for the future webinars. Thank you very much. And we are sorry we weren't able to take more questions, but if you do have questions or comments or any recommendations, please do reach out to us. Thank you again to our speakers and patients, and thank you, of course, to EPF and EMR Narrative for making this webinar possible. Thank you and have a good day.